Combination syndrome. Kelly syndrome. Definition. Combination syndrome is a condition that occurs when a complete upper denture opposes natural lower front teeth, while the lower back teeth are missing. Because there are no back teeth, the patient chews mainly with the front teeth, which are not designed to handle heavy chewing forces. As a result, too much pressure is placed on the front part of the upper jaw, causing bone loss and soft tissue changes. The condition is also called anterior hyperfunction syndrome, which simply means the front teeth are working too hard, like interns doing consultant-level work. Etiology and pathophysiology, why it happens. Normally, chewing forces are mainly carried by the posterior teeth, because they have strong bone support and a large periodontal ligament area. When posterior teeth are missing, the patient naturally starts chewing with the anterior teeth. The upper anterior ridge is covered only by denture-bearing mucosa, which is not strong enough to tolerate heavy forces. Continuous pressure on the anterior maxilla causes progressive bone resorption. As bone is lost, the denture becomes loose and unstable. When the denture becomes unstable, even more pressure is placed on the anterior ridge. This creates a vicious cycle of bone loss and denture instability. Meanwhile, the lower anterior teeth often supererupt because they do not have proper opposing contact. The main initiating factor is loss of posterior occlusal support, which basically means the back teeth have abandoned their responsibility. Characteristic clinical features, Kelly's features. Kelly described a group of features that often occur together. Primary features. The anterior maxillary ridge shows progressive resorption due to excessive pressure. The maxillary tuberosities become enlarged due to fibrous or bony overgrowth. Bone loss occurs under mandibular distal extension denture bases because of denture movement. Other associated features. Papillary hyperplasia may develop on the palate due to chronic irritation from an unstable denture. The mandibular anterior teeth often supererupt because they lack proper occlusal contact. The vertical dimension of occlusion may decrease, resulting in reduced lower facial height. The occlusal plane may become irregular due to uneven tooth wear and eruption. Epulis fissuratum may develop because of chronic irritation from denture borders. Denture retention and stability become poor. Periodontal problems may develop in remaining teeth due to uneven force distribution. The most important and most common feature is resorption of the anterior maxillary ridge, which causes most of the other problems. Typical clinical situation. The upper jaw is completely edentulous and replaced with a complete denture. The lower jaw still has natural anterior teeth. The lower posterior teeth are missing on both sides. A distal extension removable partial denture may be present in the mandible. This situation creates anterior hyperfunction because the patient is forced to chew with the front teeth. In simple words, the back teeth are on vacation and the front teeth are doing overtime. Classification, simplified. Classification depends on which teeth are missing in the maxilla. Class 1 involves a completely edentulous maxilla opposing mandibular anterior teeth. Class 2 involves a partially edentulous maxilla where anterior teeth are missing but posterior teeth are present on both sides. Class 3 involves a partially edentulous maxilla where posterior teeth are present only on one side and the anterior region is missing. All classes show anterior maxillary bone resorption as a common feature. Diagnosis. Diagnosis is based on clinical examination and patient history. The anterior maxillary ridge may appear resorbed or flabby. The maxillary tuberosities may appear enlarged. The upper denture may feel loose or unstable. The lower anterior teeth may appear elongated due to supereruption. The vertical dimension of occlusion may appear reduced, making the lower face look shorter. Bone loss may be present under mandibular distal extension denture bases. Radiographs show reduced bone height in the anterior maxilla. The denture may show uneven wear due to abnormal occlusal forces. Treatment of combination syndrome. The main goal of treatment is to restore posterior occlusal support and reduce excessive force on the anterior maxilla. Treatment planning depends on severity of bone loss, condition of remaining teeth, patient expectations, financial considerations, general health of the patient. Number 1. Conventional prosthodontic treatment. This option is used when implant treatment is not possible or when bone loss is mild to moderate. Posterior occlusal support should be re-established to distribute forces evenly. Balanced occlusion should be developed to improve denture stability. Denture bases should be accurately adapted for better retention and support. Special impression techniques are required because the anterior ridge often becomes flabby. A mucostatic impression technique is preferred to avoid distortion of mobile tissues. Materials such as light body elastomer, zinc oxide eugenol, or alginate may be used in a spaced custom tray. Accurate impressions improve denture stability and reduce tissue irritation. Management of mandibular anterior teeth may include enameloplasty to adjust tooth shape, crown reduction if teeth are supererupted. Endodontic treatment may be needed before major crown reduction. Occlusal plane correction helps distribute forces properly. Regular follow-up is necessary because ridge resorption may continue over time. Conventional dentures help, but they cannot completely stop bone loss. Number 2, extraction of mandibular anterior teeth. Extraction may be considered when mandibular anterior teeth are severely supererupted, periodontal support is poor, occlusal correction is not possible. After extraction, complete dentures are fabricated for both arches. Posterior occlusal support is re-established using complete dentures. This removes anterior hyperfunction but sacrifices natural teeth. Sometimes saving teeth is good, but sometimes letting them retire peacefully is better. Number 3, implant-supported prosthesis, most predictable option. Implants provide the best long-term results because they restore posterior support effectively. Options include implant-retained overdenture, implant-supported overdenture, fixed implant-supported prosthesis. Advantages: improved denture stability and retention, improved chewing efficiency, reduced further ridge resorption, improved patient comfort, preservation of bone volume, better distribution of occlusal forces. Implants basically tell the bone, stay where you are, we still need you. Number 4, surgical augmentation procedures. Surgery may be required when severe bone loss has already occurred. These procedures increase bone volume so implants can be placed. Examples include bone grafting procedures, sinus lift procedures, ridge augmentation procedures, zygomatic implants in severe maxillary bone loss. These procedures are usually used in advanced cases. Prevention. Early replacement of missing posterior teeth helps prevent combination syndrome. Maintaining posterior occlusal support reduces excessive load on anterior maxilla. Early implant placement helps preserve bone. Prevention is easier than treatment and definitely cheaper, which patients appreciate.